Western Australia has a huge opportunity to develop a recovery college model. You have unique demographics and a geographical spread. So my name is Jane Rennison and my usual job is I work for a very large integrated mental health and community physical trust in central and northwest London. So I'm there as the head occupational therapist and lead for recovery. So within my brief as lead for recovery is the Recovery and Wellbeing College, and we'll talk a little bit about why ours is now called Recovery and Wellbeing College. I also am responsible for peer support services, so that's both peer trainers and peer workers in our clinical settings and all our employment services. And so Recovery College for us has been part of a huge drive to embed recovery focused services, not just the education ones. So another part of my role is to work with the IMROC team, which is implementing recovery through organisational change, and that's drawn together lots of individuals from other operational services across the UK. And back in 2010, we started to work with organisations to look at what needed to be considered if we were going to change the culture and attitudes within organisations, rather than just delivering training to staff all the time around recovery focused practice. And so 10 challenges were identified, and one of those was to say to an organisation, you need to think about setting up a recovery education centre. They've now morphed really into us talking about recovery colleges, so that's what I'm going to talk to you about this evening. Having spoken to quite a lot of your colleagues now, it is very clear that you have some very unique demographics, history, the way your services are structured, commissioned, which all need to be borne in mind. But I think generally we can agree that the World Health Organization definition around the importance of recovery is shared by most nations, in fact, which is about putting the individual at the centre and supporting them to gain and regain skills, knowledge, a sense of identity. So I think we all share that. We believe that Recovery College can create conditions to help people flourish in all of that in terms of their personal recovery journey, and that actually it creates a great space for exploration, both with consumers, providers, carers, supporters. And the work that we've done in recent years, and I'll cover this a little bit more later, is recovery colleges internationally are moving in a very similar direction and finding the same things that are useful, and they're the things I want to talk about. But we need to acknowledge that recovery doesn't happen just in an organisation. And a recovery college affords opportunities to really think more systemically about how we provide services and support people. We are all in agreement, I guess, that recovery is about living a contributing, valued and satisfying life, which is about living with and beyond symptoms, with and beyond a diagnosis, and that there are key areas that we need to think about if we're going to support people to do that. So one is the acquiring of knowledge and skills that will support personal recovery, and we'll talk a little bit about workshops that you would find internationally and locally. But the work with communities is really, really important, and we found that increasingly in terms of needing to be community facing when we set up these services. Because people live and exist in their communities. Often mental health services see people as belonging to them, and when we feel we're ready to let them go, we discharge people from services back to their communities. And I think a lot of the work in recovery colleges is turning that on its head and making people realise that people belong in their communities, and when they need to use our services, then they come in and go back. And this is really important with recovery colleges. But we also know that that can be really difficult. There's a lot of stigma and prejudice out in communities, and often our recovery colleges are starting to have somewhat quite difficult conversations to say, we acknowledge that for many years in mental health services in the UK, we were trying to shoehorn people back into communities, that we would somehow work with individuals to manage their symptoms so that they appeared more normal, was a conversation I was having recently, and that then they would go back to their community. What recovery colleges are saying is the work needs to be done in communities to make them more accommodating of people who use services, whether they're mental health or alcohol and drug services. We need to support people to be able to access activities for leisure, for working, for living. Sometimes we've focused on particular areas when we're trying to work with people in clinical services. But what the students are saying consistently is we just want to be participatory citizens, and therefore we need to think about everything that goes with that. That most of the individuals who we work with in our services want no different things from those who don't use services, and so we have to see this as a kind of a totality of what people want in terms of their life. The other emerging key areas that we've noticed in most recovery colleges has been about roles and relationships, and that people in reclaiming their lives want to negotiate different kinds of relationships with their communities, their families, employers. So this has been a real emerging theme. But we also need to equip people with some basic skills and tools. And this has come through individuals saying, yes, mindfulness, we want to know all about mindfulness, but actually I also need to know about how to manage a tenancy if I've not had a flat before. So there's something about very practical skills and tools that people have been asking for. We just need to recognise in services that we can't make people recover. The best we can do working in services is create conditions that will help support people to flourish. And we do feel that recovery colleges provide just those opportunities. Our recovery college is anchored in mental health services, as are many across the UK. And one of the challenges for us is that historically we have focused on the patient in our services. That's what people tend to focus on. It's on clinical recovery. The work constantly it has improved, but I think the Recovery College has really driven forward this notion that all our clinical services need to shift from seeing the patient in our services to basically seeing the person in their life, and that now needs to shape what we actually do when people are using services. So why adult learning and education? Well, I could have put up endless slides on this. There is so much evidence around the importance of education for people and how much of the evidence shows significant reduction in symptoms, improved management of conditions, whether they be physical health or mental health. There is research that shows reduced occupancy, bed occupancy, moving through and out of services. Often the condition management programmes in the UK are very patient-led. And actually the Recovery College is about how we bring together both sets of experts, learned expertise and also lived expertise. And so this is, again, it's a very different way, I think, of trying to support individuals to better manage their health and well-being. One area that we talked about in previous sessions where there's a real opportunity for Western Australia that hasn't really been explored to such an extent in relation to education is the work around spatiality. So there is something very special that happens in a recovery college in terms of learning. And that is the bringing together of people and how not only do students learn, but those who are facilitating the training as well. And there is a little bit written around this, and it is about how we create conditions that nurture those conversations. And I think Western Australia have a real opportunity to kind of build that in from the start and to try and look at that uniqueness and perhaps draw on already, what's happening in Western Australia, because I don't think it's been explored very much at all, but is a key ingredient. I think it's useful before we go on to say what is it, what do we view as an in-rot recovery college and what might not be, if we look at some of the shifting of focus that's had to happen as a result of having a recovery college. The therapeutic model, we know focuses, apart from symptoms, on pathology, on diagnosis, and really, in summary, we always say that we're moving from a paradigm of therapy which is shifting from what's wrong to what's strong, and it's very simple. It's not rocket science at all. But I think recovery colleges, because they sit within an educational paradigm, it lends itself so well to that. One of the things that we've done, and I can put my hands up because I'm an occupational therapist, is that we have turned almost all activities into therapy, and we therapise many, many things. So, for example, as an occupational therapist, I've obviously facilitated therapy programmes of people using public transport, gardening, and these are natural things for many people, but we've gone to the extreme of therapising many, many everyday activities. And I think what a recovery college does is it regrounds us and says, well, when it comes to reading groups, reading therapy groups are very important, but why not have a workshop that simply is about how good reading can be for your personal recovery? So we have to shift from this therapy to education. The other difference we've noticed in moving from therapy to education is particularly around people's aspirations, dreams, hopes, ambitions, and that what you would see typically on somebody's individual learning plan, education plan, looks very different to what we see typically on a therapeutic care plan. And students are saying, this is the bit that really matters to me, my hopes and my aspirations. And that's what's discussed in a recovery college. We see this shift, and it's a power shift most definitely, where the therapist is the expert, and the patient viewed as a non-expert, that's the risk, over to where this is better balanced. In a recovery college, everyone is a student. If this was a workshop, unless you decided to say, you would not know who was a staff member, who was general public, who was using services, who was supporting and caring for people. And that's really, really important. And in fact, a lesson learned in a lot of recovery colleges has been that when we start a workshop, the kind of typical ways to say who you are and say a little bit about you. And what we were finding was that invariably people identify with what they do. We are occupational beings. We are largely defined by what we do. And so often it was, my name's Jane and I'm an OT. My name's Fred and I'm a service user. And it immediately created this difference. So what we do now, which fits perfectly with co-production, is we tend to say, what would you like to get from today, but also what will you bring today? Because we really firmly believe that everybody has got something to contribute when they come to a workshop. And that immediately doesn't set apart, particularly professional colleagues who like to hide behind their job title, and that sets them apart perhaps, or they like to think so. So everybody comes as a student and everybody self-selects. There's no referrals, there's no discharge. We'll see a video later on that certainly in most colleges people just sign up either through the prospectus or online. They fill out an enrolment form like a college, and that's it, they are students. So they can work with a peer tutor, and we'll talk a little bit about that if they want some guidance, but ordinarily students completely self-select what courses they want and decide when they've used the recovery college sufficiently. One of the very interesting things, and we were talking about this in the previous sessions, is how a recovery college can bring about other systemic changes really in communities and organisations. And one thing that many colleges have noted is starting to use different language in other areas of the work. And a couple of examples that I would give you are often in clinical services, documents and discussions are about managing people's risk, assessment of risk, management of risk, and that somehow individuals are viewed as a bundle of risks that professionals will somehow manage. And the work through the Recovery College and the discussion has really led to a shifting in thinking in many trusts, which is that we need to talk about safety instead of risk. Because many of our students say, Actually, I just want to keep safe doing the things I want to do in life. I don't view myself as a risk, so why would professionals? So the language of risk recovery and safety has been a very interesting discussion. The next thing is around our community teams who now invite people for a consultation rather than an assessment. And again, our students were saying, when you come into mental health or addiction services, a community team will get in touch and invite you to be assessed by one of their colleagues. And that immediately sets up this notion that somebody will be doing something to me. They will hold the power, they will assess me as a problem and decide if they can help. Whereas what they really wanted was the words that are adopted more in physical health care, which is if I had damaged tendons in my leg, I would be invited to a consultation with a consultant probably. And immediately that brings the power balance that this person's going to consult with me about what my difficulties are and what they can offer. And so they're and it might be very different in Australia, but there are these key words that people are saying through the Recovery College, we just need to rethink what message this gives in terms of lack of parity, in terms of power. So the journey so far, originally Boston Recovery Education Centre led the way and is still running. It was and still remains a peer-led service. On the way back from visiting there, Dr. Julie Repper and Dr. Rachel Perkins, who work with the IMROC team, decided they wanted to do something slightly different that was based on co-production. And that was where the idea was born, really, for a recovery college. Rachel set up the first one in southwest London, and I know has toured extensively around Australia, talking about her experiences. And then Julie set one up in Nottingham, and then we set one up in CNWL. And by 2014, there were 8 recovery colleges, and now there are around 80, including in the UK and other parts of the world. And we will come back to Australia and what's happening in Australia shortly. More recently, which again has stimulated quite interesting discussion and did with colleagues over the past couple of days, is the work that we're doing in Europe. And although the model is exactly the same really as a recovery college, those colleagues working across Germany, Netherlands, Italy, Bulgaria and Poland have decided to call their colleges empowerment colleges. And that's primarily because recovery doesn't translate that easily, but they believe in their systems there is much more to do around empowering people first, and talking about prejudice and stigma, rights, before, as they say, we can get on some of the woollier recovery-focused workshops such as mindfulness. They actually believe that there are some real issues that need naming. And colleagues yesterday were saying that may need to be held in mind when thinking about the first courses and workshops that are delivered in Australia, because for some people those remain real issues. We've already alluded earlier to the literature search, which I have to commend to you to read and download off the website because it's a phenomenal piece of work. So all I've done really is talked very generically about some of the key emerging themes which have led from the first briefing paper to the more recent one on the right. There is no doubt that recovery colleges are very popular with students, and that's both those who use services, those who support them, and staff. I, to date, have had no negative feedback about, in terms of that people think recovery colleges are a poor idea. There's quite a lot of increasing evidence that they are engaging people who either have never used traditional services, and we had examples, we were talking this morning about those using children and adolescent services who perhaps haven't gone into the system of using typical day services, but also people who'd become quite disillusioned with some parts of the mental health system. And one of our students who was quite critical of traditional day services in the UK made the comment that they felt that day services had become refuges of low expectation. And that led to a very interesting discussion actually about not only day services but perhaps some community teams as well. But they found the Recovery College a very different, vibrant environment. Another issue has been that attendance rates are consistently high and comparable to further education. And this has been very interesting when we compare it to therapeutic group participation in our trust. So we deliver Recovery College courses in our secure services and in our prison services. And where we also deliver therapeutic groups, the attendance might be 3 or 4 people on the ward, whereas Recovery College courses delivered in those settings are getting 10 to 15 of the people who are residing in those settings. So there is something very exciting and very different that is actually engaging people, particularly on our male secure unit, who would typically not engage with anything, but they want to be a part of this. Interestingly, in our prisons, one of our most popular workshops is around understanding self-harm. And that has been very interesting because the prisoners have said normally people do not talk about this in prisons, even though we know it's just a shocking problem. So there's some very interesting things emerging in terms of how people are using this opportunity, this educational space. In terms of improved outcomes, a lot of it is subjective, and I think the biggest thing that we hear from people is in terms of hope and their sense of their hopefulness. And that is about recovery, their self and relationships. They are always the things that emerge, and that actually they are being equipped with skills and knowledge, which means that they can be more participatory citizens, which is what people are wanting. More research needs to be done on the impact on services in terms of cost savings. There is some work that's been done to show that people decrease their use of existing services. We operate a care coordination kind of system in community, and care coordinators are saying we're seeing some of our service users less because they just don't need to come and check in with us. Some very interesting work that we've been doing with GPs. So we have a Recovery College spoke with a GP practice called Healthy Living in Partnership. And that piece of work it was twofold really. One was to equip GP staff and healthcare staff working in medical centres to better understand mental health and all the associated challenges. But equally, it was about how do we support GPs to better work with those clients they were defining as frequent attenders who would repeatedly come to GP practices, but it somehow felt that people would be stuck. They were quite stuck. We've noted from our results, which we're just writing up, there's less attendance at GP practice, but more importantly, GPs are saying the nature of the conversation is changing. So it's not the same conversation when people are turning up, but people are now talking about how they can better manage their condition. And that's a big difference, a huge difference. So there's lots of research going on, but lots more to do. So I guess this is where it becomes a little bit more contentious. And the reason that I've got a couple of slides about when is a recovery college not a recovery college is this very much comes from an IMROC perspective in terms of what we see are the key ingredients and principles that we would call a recovery college. So out of those 80 around the world, a colleague described it the other day to me saying, you know, there's a few that have gone feral. Jane, and I will talk a little bit about perhaps when we feel that people are veering off a little bit from what we would say were the core principles. Absolutely essential, and there's just no way that it can't happen, and that's co-production. So the whole point is to bring together different expertise, those with lived experience and expertise of living with conditions, or even using different services, People bring their lived and life experiences, and then the other side of that is those who've got learnt experience. So they tend to be, in our case, in our organisation, nurses, doctors, OTs. In terms of those from the community setting, we have educationalists who come in. For example, if we're delivering a workshop on managing a tenancy, we're going to do that with experts from a housing association. It's not something that health staff have great knowledge of. So it's all that expertise coming together. Co-production in a recovery college happens operationally as well. So we say that everything has to be co-produced in terms of policy, guidelines, the environment, recruitment. So there's the operational side. In terms of the delivery of the recovery college and its workshops, that always has to be that expertise that comes together to co-produce. So all workshops are co-designed. All workshops are co-delivered by somebody with lived experience. In our college, we call those individuals peer trainers. Those who come from a professional background, we call mental health prac trainers. They come together, they facilitate a workshop to a mixed audience. It really is very simple and straightforward. Unfortunately, what we've seen is that in some areas, there's some tokenistic involvement that really isn't co-production. And I think, we're all on a journey with co-production, but some people talk about co-production and it really isn't. So an example would be an occupational therapist turning up with their anxiety management course under their arm because they've been delivering it for years, and asking one of our peers what they think and would they like to tweak it. And we've seen a lot of that in a lot of recovery colleges, I have to say. And there's a lot of egos being bruised because we've had to say, and OTs and psychologists have been the worst in doing this, is saying, no, park all that. Bring your knowledge in your head and your experience of delivering it, but let's start with a big blank sheet of paper. So yeah, that's been a very interesting journey, I have to say. But I would say that equally we've seen colleges that are very peer-led, and we would say that that's just the other end of the spectrum. We have to do this together if we're going to make a difference. And I did read on one website about a peer trainer who, in a way, a bit like myself. So I'm an occupational therapist, but I've also got lived experience of severe depression many years ago. And a trainer in my situation on one website said, well, I internally co-produce because I bring my lived experience and my professional expertise. And we would say, no, that's just not the way to co-produce at all. So you have to be very careful, I think, about ensuring this balance. A physical base is really important, and that may look very different in different recovery colleges, but we would argue that a sense of belonging for individuals is really, really important. And that's even if you have a very small physical base and lots of spokes and lots of activities going on out in your communities. Most recovery colleges would say that you really need to have a resource for people to be able to access information about recovery. And we met a colleague this morning who was saying that she was already gathering books and resources for a library, which was really quite exciting. Not recovery college yet, but yeah, we've got the library, which was amazing, and people were showing a lot of interest in that because a lot of people draw on resources already, and we need to be sharing this. Libraries have been set up in very different ways in recovery colleges across the world. So there's an amazing example in Birmingham and Solihull in the Midlands in the UK, where they have opened up all their medical libraries within their healthcare settings and said, you know what, why is this private knowledge just for the doctors? We should all be accessing things like this. So they've actually opened their staff medical libraries. Another example in community libraries is that we've seen in some areas your typical community library now extending its choice of recovery-focused literature, which wouldn't have typically been there as a result of partnership working. And then an example would be in Nottingham, where literally in their recovery college they have a resource library. So there's lots of different ways of doing it. But we know that knowledge is power, so the resource library really, really does matter. Where there are virtual colleges, it's very hard in terms of identity for people, and is also very challenging in terms of providing this recovery library resource. Recovery colleges must operate on an educational and college principle. For all recovery colleges that we've come across, certainly in the UK and most around the world, is that they operate on a 3-term basis, like a college, and that we certainly review our courses, our workshops. We provide learning opportunities for our trainers during those holidays from the teaching. All courses and workshops have course plans, lesson plans, very much the same as in an adult education environment. We have curriculum and course development, which is very similar, and that all sits in with a very tight quality assurance panel and forms, and that it very is educationally focused. One of the problems we've seen, and this is where it does start getting a little contentious, because people have made very good arguments for why they might need to make up for shortcomings in the existing services, is that some recovery colleges go beyond education. So an example would be in the UK, we've got an amazing recovery college for homeless people, St Mungo's, and it's doing some incredible work. But you just turn into their prospectus and they also offer access to one-to-one psychotherapy. Now, that's not education. And they're doing that because they're saying that the population who use their recovery college can't readily access psychotherapy. But that's not a reason to put it into a recovery college. So we have to be really careful about, what lines will you be prepared to cross, and where are you going to stay firmly educational. And it matters because we know that some of the issues that get raised in some of the workshops can be really quite personal and challenging issues for people. And what we don't want is to create a space where trainers become pseudo-therapists, because then it becomes a very unsafe space. So we have to be really clear. Most of the recovery colleges in the UK, including ours, that's part of a much bigger mental health system, we don't take notes, we don't access electronic patient records. Individuals come as students and their attendance isn't recorded, apart from us keeping numbers so we can kind of keep, uptake of the recovery college. So that these things have to be thought through, because we've seen rock climbing, guitar playing, all sorts of things appearing in recovery colleges, and we would say that they're better sitting in mainstream colleges than in our recovery colleges. So we do need to be mindful that what we set up isn't creating barriers to inclusion by drawing people into our recovery colleges when they could be using community services and not coming anywhere near a recovery college. No exclusion criteria. A recovery college is for everyone. It will depend on funding. I think that's the really exciting thing that's happening in Western Australia, is that you're bringing together the alcohol and drug services with mental health. That's great. Most of the recovery colleges internationally are primarily focused on mental health, but of course people who are using our alcohol and drug services can use them. But I think there are amazing opportunities for doing something slightly different in Western Australia, which is great. Really, apart from parameters of funding, which may exclude groups of people, often the general public, is in our secure settings. We've got recovery college workshops happening in Broadmoor, in West London, in Rampton, in Nottingham. We've got them in our prisons. So obviously people are excluded, apart from prisoners and prison officers, and mental health workers as well, who attend the workshops in those settings. We do need to think quite carefully as well about, if we are starting to exclude groups, where they are located in the communities, because otherwise we risk creating ghettos for people who use services. And we've found a few examples in the UK where typically, and OTs have been guilty of this for many years, herding people into libraries and sports centres. And we have to be really careful that if we're using community venues, that these are open to everybody and that people will be curious about what's going on behind closed doors. Otherwise, we risk creating more ghettos, and we've got to be so careful about that. Students are offered a personal tutor. Staff don't tend to take that up, but I would say that primarily service user, consumer students take this opportunity, and many of the supporters, their carers who attend, and that involves developing an individual learning plan. So at the beginning of a term, a student might come along and sit down with a peer, and we've got all sorts of titles in different recovery college. We've got study buddies, peer learning advisors, a whole host of names, but essentially they do the same thing. They guide people to see what courses and workshops they would like to attend, what are their hopes and aspirations for the college, and to think about what is the pathway through, because again, we don't want to create somewhere where somebody's going to come and get stuck for years. It would defeat the object. At the end of term, they often sit down again and review their learning plan and decide if they're going to attend something next term. And it just keeps people moving through, and so that we don't have serial attenders, I guess. It just keeps everything really live. Some colleges have made that so bureaucratic, it's actually getting in the way of certain groups attending. So one college recently has insisted that any staff as well from the mental health service have to have an ILP. And of course, people just don't have time. Nurses, doctors, there's no way. So it means they're not going to the recovery college, which is a huge shame. It's not a substitute, as I've said, for traditional assessment and treatment. And we do know that people are straying into therapy, which makes it a very unsafe space. And that actually a number of places have simply renamed day centres as colleges. And which again is a real shame, because they're very different things. It's not a substitute for mainstream colleges. We don't need to replicate. There is some really good stuff happening, and I know you've got quite a rigorous system over here around adult education, but we need to remain community facing. There's been some real slippage in some colleges where we've seen sewing classes, caving, dancing, and we would say they belong in a mainstream college, or if they're more like therapeutic groups, keep them in therapeutic groups, but keep really focused and clear that actually what we're offering is very different. Everything's underpinned by recovery principles. For us, our strapline is hope, opportunity and control. And that we need to keep very focused on why we're offering this workshop here rather than it being anywhere else. And that is a lot of work. I'm sure Pam knows that, when you're looking at your prospectus, because if you listen to students will possibly ask for a dancing workshop. And we've had to manage expectation a lot in recovery colleges, saying, no, that's not what we're going to do here. And that's really important. I think one colleague, a peer trainer who recently, we were reviewing another recovery college, and there was dancing and he said, how do you justify this? Is it dancing with hope? He said, tongue in cheek. But there is an issue, because actually by providing that, it means people aren't going to access the dancing classes, which we need to support them with round the corner. So these things are really important, and we just must resist the urge to operate a recovery college in splendid isolation, because that's the other risk. I thought it might be helpful just to put a picture of a recovery college in case you're thinking, what does one look like? This is actually Nottingham, and I think really I'm showing it because it's to say that the space is usually co-produced, so the information that goes up usually goes up at the request of students. What is it that we want to know? They're very hopeful environments, I have to say. I don't think I've been in a depressing recovery college yet. So I've said what the main principles are, and since those original principles, which were defined, back in kind of 2010 and 11, is the research still shows that these key principles are so important, And without question, if you had to even pare it down further, these are the 4 things that recovery colleges have to reflect: recovery principles, and that's personal recovery principles, has to be founded on co-production, isn't peer-led, isn't led by services, is for everyone, and operates on college principles, because that's what keeps us different, and that's what keeps the whole thing really, really healthy. I did just want to say a little bit more about co-production, though. The Nesta definition, there are lots of definitions, and I think we can agree that, you know, in terms of public services, there's a lot of work now around co-production, and how we bring together services and communities to really affect systemic changes across our systems. I think this is the most important bit, which most of our early recovery colleges didn't give enough thought to soon enough. So we patted ourselves on the back, but actually what we were doing was fairly okay engagement and involvement. It wasn't co-production. And I would suggest that as the work in Western Australia goes forward, is that actually there are workshops on co-production before this work even starts, because unless you get that right, it really is quite tokenistic in terms of how services, recovery colleges will be progressed. We very naively thought this way of working would be easy, quick and cheap, and it was none of the above. It wasn't easy bringing people together who actually had quite polarised views and visions of services and what people might need, or it wasn't quick, that was for sure. And in setting up our recovery college and workshops, in the end we had to agree that any workshop we would agree would have a whole day, 7.5 hours at the very least, of time put aside for people to co-produce a workshop, even though they brought lots of expertise. I think we're getting better at it now because it's part of the fabric in many of recovery colleges. But the other thing is, it wasn't cheap. I think we wanted to make sure that people were rewarded for their involvement and had to think about how that worked for consumers who were co-producing. Staff were usually already being paid, so it was their time from their service. But our consumers were coming in their own time, and we had to think very carefully about how that would be rewarded, and we had to get that right. I think many recovery colleges have found a good way of working in terms of financial reward, but also creating opportunities for people who just want to volunteer and give back. But that has to be explicit, I think, at the start, and it's a very sensitive area. The other imbalance often, I think, that recovery colleges have found is that there is an imbalance of access to resources. So it's usually staff in organisations who access the photocopier, the paper, people's electronic diaries. It's been very interesting often that the professionals will huddle and set meeting dates and then will tell the consumers that's when we're meeting because we've all checked our diaries. And it's just little things like this that seem to have happened very early on in recovery colleges, and it causes offence. Interestingly, a lot of recovery colleges have reported that it was our peer-led and consumer organisations who found the co-production process very challenging, and we've explored that with some of our consumer groups. And I think they've made a very fair point. And one colleague in Mind in London said to me, we have had to shout for so loud to be heard in a much bigger system that now you're saying, don't shout, you're going to listen to us. We're not that trusting, actually. So there's been some really interesting conversations about some of our consumer organisations thinking that we're not going to share the power at this point. Because we're quite cynical, and that's been a very interesting journey, and I think we've come a long way with that now, because we really need to reach this point, and most people would not have seen the people in the corner, and I think this is the point of co-production, that whether it be peers or mental health practitioners who come together, more often than not, most people think that they know most things, and it's really only through the process of co-production that you start to see an entire picture quite differently, and that's the exciting thing, I think, about recovery colleges, because not only does it bring together different views and opinions, but it starts to identify people's talents and skills that go way beyond being a nurse or way beyond being a service user or a carer, if it's done properly. These are just examples of some course prospectuses, just really to show you the variation. And people do like a prospectus, I have to say, something very tangible to hold on. But I did just want to say a little bit about, I know some of you know more about recovery colleges than others, but I did just want to kind of give a few examples really of what workshops and courses might be included. Generally, I would say that most recovery colleges internationally do split their courses into these areas roughly. I think, you see in most prospectuses these groupings. So just to say, in ours, so in understanding health difficulties, the sort of workshops that we would include there around understanding alcohol and drug use, and there's lots of understanding, so understanding anxiety, depression, hearing voices, psychosis, self-harm, personality disorder, mental health medication, hoarding. We've now moved a lot more as well into physical health, partly because our organisation works with community physical health services, but equally there just is no mileage in keeping things really separate, because most people with a long-term physical health condition also experience some level of emotional mental distress. And similarly, we know from many of our students that living with a mental health condition, they also experience physical health issues. Most of our students are saying the sooner we start to talk about health instead of mental health or physical health, the better. But it was their push for why we included wellbeing now in our Recovery and Wellbeing College, because that's what it's about. It's about wellbeing. So we also have courses in this section around sickle cell, chronic pain. We're doing a lot of work with palliative care services, because even though you might be dying of cancer, you're still living with dying, and hope, opportunity and control matter just as much. So we're really having to think a lot more creatively about the courses and workshops we offer people. Health and wellbeing tend to be things around a good night's sleep. Lots of research around that now. Healthy eating, exercising, healthy heart, real public health agenda stuff that impacts on all of us. Type 2 diabetes, that kind of thing. Then understanding and developing ourselves. This is really, I think, the real recovery stuff, around self-discovery, telling my story, understanding anger, bereavement, mindfulness, self-compassion. One of the very interesting things that happened in many recovery colleges in the UK was we always knew that there was a challenge around stigma and discrimination, but what I think services hadn't realised was the level of self-stigma that goes on. And that's, those kind of workshops have become incredibly popular in taking control and rebuilding a life. Exploring what works for me, planning life beyond services, prison, living with change, getting the best out of your general practitioner, your psychiatrist, those kind of things. And then the recovery focused practice and getting involved. I think our journey also involves supporting people to come into our organisation and influence in other ways. So we really need to co-produce strategy at the top of the organisation, and these kind of workshops help people to get involved. So equip people with skills around organising and chairing meetings, really understanding co-production. We've got peer worker courses so that people can become peer workers. And that leads nicely into employment and work related, which I would say in most of the very established recovery colleges is where we've seen a huge growth in workshops and courses. I think at the minute we offer around 10 employment related courses, because really people have come forward and said, work matters. If it's voluntary work, paid work, whatever, but work matters. In terms of how those workshops are delivered, we offer a range, as do most recovery colleges. We have half-day workshops, one-day workshops, a day a week for 6-week courses. Taster sessions are very popular for people who are a little bit suspicious about what a recovery college might be. But we also offer snapshots, and they're in our inpatient settings. And we believe that people who, especially if you can't leave an inpatient ward, it's really important to say to people, you can be part of some education and learning at the earliest opportunity. As soon as you come out of hospital, we want you to engage in this. And so, for example, if it was a half-day workshop on living with change, we might do a half-hour workshop. Just really, it's a snapshot of that on the inpatient setting, because we need to try and engage people much sooner in acquiring knowledge and skills. So yeah, we offer it in a whole range of ways. So, recovery colleges in Australia. So the first recovery college, which was Your Mind in Victoria and South Australia, came about, I believe, in 2013. And having looked at their website, it seems that Victoria have around 7 locations and South Australia 2 locations, and that there are kind of 0 to 3 courses per term delivered there. Your first public health, I guess, recovery college is the one that's split across southeastern and western Sydney. And looking at their prospectus, it's very similar to the work that we do, and they seem to offer, more so than us, a lot of courses in different languages that are delivered across a number of localities. I would commend an article that they've written recently. It was at Christmas in the Mental Health and Social Inclusion Journal. It is in your review, which was called Walking Side by Side, and it's a great article about the experience of teachers and learners in their recovery college. It's a very good and interesting article. And then, of course, there's Broome. And I thought, Pam, you might want to say something.
Well, I'd like to add to that. You've left out Esperance.
Oh, sorry.
Yes, we've established a satellite
in
Esperance.
Okay.
And it's looking towards producing some courses in mid-May.
Oh, fantastic. Do people know about Broome, or I don't know whether you all know each other?
Where's the Broome person?
But I thought, are they not connected, Broome and the one you're talking about?
Well, they're a long way apart. I live in Esperance, and Broome's a fair way away.
Yeah, I've not quite got to grips with your geography.
Well, I gave a paper on recovery college at the Regional and Rural Conference in Broome not that long ago, and it's a very confusing situation up there.
Okay. So there's still lots to learn about how to drive forward recovery colleges in Western Australia?
It's a very different approach.
Okay.
But I think one of the most difficult things, and it's throughout the state, it's not confined to this, is that communication, because we're just all so far apart.
Yeah. Well, interestingly, we talked about that a little bit this morning, about your demographics, and the nearest comparison, I guess, I could make is the recovery college model in Ireland, in Southern Ireland, which again is rather large in terms of an area. But they've done a wonderful thing, and they have a recovery college double-decker bus, which actually goes out to remote sites and delivers the workshops that are delivered from the hub, and that they can take their resource library with them. So I think there are some really creative ways that we can think about, and perhaps we'll come on to that a bit more at the end as well. What courses are you going to prioritise?
One has come from the suggestion of a consumer who's on our action group, and it's about how she herself explored what were the ways for her to understand her own situation to overcome it. So she's combining with another person with that learned experience.
Fantastic.
And the other one is we're combining with the folk from Hope Community Services, which is drug and alcohol.
Fantastic.
And once again, a consumer, which in a small country town, a consumer's prepared to get up there and co-produce this is just phenomenal. And they're looking at addiction. And what is addiction?
Brilliant.
From chocolate through to methamphetamine.
Yeah, fantastic. And I think the wonderful thing about recovery colleges is I often put up a slide of Kevin Costner in Field of Dreams, because build it and they will come. People will come to workshops and they will then make suggestions. And certainly in our first term in 2012, we developed 10 workshops over a 13-week period. And now we've got 100, you know, and that is because of students saying this is really what we need to know about. And I think that's what's really exciting. I just want to touch on some of the impacts that have been found worldwide, really. I'm not going to say anything in great detail about trainers, but there is an increasing amount of literature being written about the benefits of being a peer trainer in a recovery college. And what that gives to oneself, not just in terms of employment, but giving back and experiencing more learning. The reason I've got the cartoon at the bottom is this really sums up our journey and how co-production brought us to a halt initially. There were a number of professionals who were in the starting blocks, really keen on this idea, and we ambled off, and then we picked up a pace and ploughed ahead. And it was our consumers that said, well, you're doing what you always do. You know, professionals are saying what they think we want. You'll design it and they then invite us to come and play. And that's not going to happen with this. And it did slow us down. It did. But it's been far better because now we're all moving together at the same pace. And I think that's the joy of this process in WA, that it feels like it's being, you know, co-produced from day one, really. So in terms of the impact on the individual student, and this is primarily, I'm thinking of consumers, is there's been some really interesting experiences of breaking down the them and us. And I think typically people think of the them and us being people who deliver services and people who receive services. Some of the interesting stuff that's happened is there is that breaking down of that barrier, but often I think in services we hadn't quite realised that there was a hierarchy within our consumer group about whose condition perhaps was more complex or more important, and that opened up a lot of dialogue. So, you know, literally hearing in workshops, what do you mean you've only got depression? I have psychosis. And this was a very interesting phenomenon to many of us in services, delivering services. We hadn't quite realised that that was going on. So it fits in with the stigma discussion, actually, and that can really be explored in recovery colleges. There was also quite an issue between those who were using typical mental health services and those who were using our addiction services. There was a them and us between people who were coming and participating with a physical health condition and a mental health condition. But of course, a recovery college can just throw that all up in the air and can start naming some of that and talking about it, which is really, really important. Most of us, when we wobble, want to be able to self-write and get back on track without using services, and students report that that's what a recovery college can do in terms of equipping them with skills and knowledge, or even where to find different support rather than using services. Certainly there are reports around people increasing their sense of responsibility for managing their own condition and broader well-being, and that's been borne out as well by colleagues who work in services, saying that they've noticed a marked difference in somebody's confidence in perhaps managing their own well-being. Definitely offers great opportunities to participate in communities, and I think the general feedback tends to fall into three key areas, which is in the UK, voting rights, people actually being able to vote and inform what happens in their community on all sorts of level. Getting a job has been incredibly important for people feeling that they're actively participating in their communities, and simply getting a life is the quote that often happens in our recovery college. That's what it's helped me do, get a life beyond services. Changing the nature of conversations and facilitating shared decision making has been a really interesting one. I'm going to say a little bit more about that. But first, I just want to read you a quote which came from one of our consultant psychiatrists, and I know Jo would not have a problem with me describing her as a dinosaur a few years ago. She would be a doctor who would say, Jane, I've got somebody to refer, But anyway, we've kind of ground her down and she doesn't say that anymore. But what she did say was, today I experienced the most wonderful thing in a meeting with a service user who has just completed the Telling My Story course. It was a scheduled review, but I was taken completely by surprise and, to be honest, moved to tears by her sharing with me her completed end piece that she'd brought with her to our meeting. She read out the words explaining how she saw her recovery with such openness, honest reflection, hope and pride. And interestingly, that individual she's talking about is now a peer trainer. And it's led to really interesting discussions with particularly our doctors about how the relationships change from doctor-patient to now colleague, actually, and training. And that, again, has opened up a lot of discussion around shared decision-making and how we can change the nature of day-to-day conversations. So what we've noticed is that conversation has changed in our services as well about what people's aspirations and hopes are, and that anything's possible. So there's a far more hopeful dialogue, that we've really started to shift to a strengths model rather than this endless listing of problems. That the Recovery College, very much like that diagram, has brought together lots of people and things. So it's brought together students who are now networking. It brings together people who are delivering services and receiving services, students and community, mental health services and community organisations. It's just brought together lots of new partnerships. Which goes way beyond what we typically did, certainly in the UK, in our mental health services. And staff have started to adopt a coaching approach with people, which encourages and brings out the strengths of others rather than this therapist and service user. I've already touched on employment and education, and that has been absolutely key in actually looking at people's care plans within our settings, that these things are featuring far more heavily than concordance with medication and making sure that you go see your GP. There's been a real change in the flavour of individual care plans in services. In terms of organisations, we're seeing across the land in the UK especially, massive shifts in the culture of organisations, although we know we've got some way to go, particularly with some of our psychiatrist colleagues. And I've read an article flying over here that consultancy recovery colleges has been peer-led, as though somehow that means something. It's quite interesting. But do consultants come to our recovery college? Not very often. They've got nothing to learn. What we have done in our organisation, which is a handy hint, is we get junior doctors when they're fresh and they arrive in the organisation, and we tell them that they have to, as part of their induction, come to the recovery college. It's been really useful though, because I think for a junior doctor to actually immediately experience that shared learning is a bit of an eye-opener. So we're seeing tangible steps in transforming our workforce. Our peer trainers are hugely respected in our organisation. The risk is they get called in to do all sorts, and at some recovery colleges we kind of joke that they're rent-a-peer services, because they've got high profile now in our organisation. So I think our organisation, like others, has got into this, well, we'll use them because, we work with them now. What we're doing is saying we need to transform our workforce by having peers in our clinical services too. And so as a result of this journey, in many recovery colleges, we're seeing the increase in peers in clinical services. I think we've gone up to 45 in our central services. It challenges stigma and prejudice, and I think this is a really big one for us in the UK, because although we'd like to believe there isn't stigma and prejudice in mental health services, there is, without question. And, it's been named in the Recovery College. It emerges as an elephant in the room and gets addressed now rather than being swept under the carpet. And there has been huge challenge, particularly by consumers to staff, about some of the language they use, some of the sweeping statements they might make. Previously, I think this was just swept away, but it can't escape in a recovery college, and that's got to be a good thing within an organisation. So it's openly discussed, certainly in CNWL now. We've raised expectations from staff, especially saying, yes, but we've tried that, to yes, how can we do this? One of the most key things I think in organisations is shifting the silo mentality, and you're already setting yourselves up to do that by bringing together elements of service, mental health and addiction services. But given that this recovery college affords an opportunity for anybody to attend, it means that if apart from us not knowing in this room whether you were a consumer or staff member, it also means that we have found somebody living with an eating disorder might be on a dementia workshop, sat with somebody who's using alcohol services and sees a nurse who cared for them 15 years ago. And it's starting to break down this silo mentality, you know, that we often have in services of grouping service users together as though they have these unique issues when actually most of us are bothered about our well-being. Other areas where that's been amazing and leads on to the next point really about staff feeling that they've been reminded of why they came to work here has been evident with inpatient staff. So inpatient nursing staff come into the recovery college and sitting next to individuals who they might have cared for some time ago, seeing that they're further down their recovery journey. Some of the stories that we've had from our ward managers and matrons has been amazing. A recent one was, not only have I just seen Will, who I cared for many months ago when she was very, very ill, but she's now working as a trainer and is training me. I mean, this is just phenomenal in terms of breaking down stigma and barriers. And, you know, and why wouldn't that happen? But if you're stuck on an inpatient unit day in, day out, you get very fixed about where people are at living with their condition. And that's been very exciting. It connects clinical with non-clinical. So within organisations, of course, people from human resources and the finance department come to our recovery college. And as an accountant recently said to me, this is why I sit in a dark room counting pennies, because it's for this. And so it actually starts to bring lots of people together, which is fantastic. Impact on practice within organisations, and this also applies to community organisations, is that, you know, we're seeing many organisations really progress now around recovery-focused practice. Within many of the mental health trusts, we're seeing the use of team recovery implementation plans. Things have emerged such as so with regards to therapeutic management of violence and aggression, I understand here you too are trying to reduce physical interventions on inpatient settings. And what happened in the recovery college was, as we brought together consumers and staff, they got wind of our training when we trained staff in this therapeutic management of aggression and violence. And peers were saying, why are staff teaching staff? You should have peers teaching staff. I've been restrained on a ward. I'm the person who should be telling you how it should be done. So we've spent 18 months as a result of our recovery college reviewing all our training and have now employed 2 peer trainers. And they're working alongside mental health practitioner trainers to co-produce that training. Because we keep moving staff into rooms and training them and things and just not involving usually the recipients of that care. Every interaction creates a recovery-focused opportunity, and I think now we're seeing recovery colleges really supporting services to become stepping stones to inclusion rather than historical exclusion. I just want to show you, and I'll see if I can manage to do this. Okay, so that's CNWL's film. Other films are available and they will say very similar things. That is how recovery colleges are evolving. I just wanted to finish off really with a summary, and this is really what goes on in my head. Where are we at with recovery colleges? I think the top left picture is where we were locking horns constantly. Professionals, service users, carers, service users, community services. And actually what co-production has made us realise is we're often just coming from a completely different angle, but it's the same thing. And that's been a huge shift, I think, in terms of saying, you know what, we can view things differently, but together we'll create a new picture. Recovery colleges in most areas are the heartbeat now, and they are pumping out recovery principles up and down organisations, because it was very much the missing jigsaw piece in a lot of organisations. They needed to do something differently that would drive forward recovery. We had some interesting conversations this morning this afternoon and yesterday about the word recovery. Certainly there is at least one children and adolescent recovery college, and they call it a discovery college, because as far as the young people were concerned, they've got nothing to recover from. They want to discover a life. Exactly the same conversation was had around learning disabilities. So I work very closely with one of our paid trainers who's got a learning disability, Santino, and he shoved me one day and he said, you know, we keep talking about recovery. What do I have to recover from, Jane? I just want to discover a life. I'm not getting rid of my learning disability. So we revisited many workshops and co-produced them with colleagues in learning disability service, both people using services, carers and staff. And they really do talk about discovering a life, really. So language is important and needs to be thought about, and that came up earlier today. The guy on the cartoon, you might not be able to read, but he's leaving his valuables there on the shelf, which happen to be his heart and his brain as he goes into work. And many of our staff have said that recovery colleges have reconnected them with why they came into mental health work and working in addictions. And in fact, many UK recovery colleges now have resulted in organisations establishing lived experience networks for their existing staff. Because we have found time and time again, staff coming to recovery college courses are actually now stepping forward and saying, me too. I will come and talk about it in a recovery college, but I will not be telling my nursing colleagues when I get back on the ward that I've struggled with bipolar. So actually what has emerged are lived experience networks for staff, and we're seeing them in many, many organisations now, and that has really been informed by recovery colleges. The goldfish is recovery, really. In many places, recovery colleges have just meant recovery is now visible in a much larger pond. Power and stigma have been named very much as elephants in the room, and they're not going to go away now. They can no longer be swept under the carpet. The peacock represents egos. There have been, most recovery colleges find there are a lot of egos, and that's both professionals who find it difficult to accept that they know less than they thought they knew. So that's quite a challenge. We've also had some service users, consumers, who are very well known in some of our systems, who feel that they're the only voice. What recovery colleges have afforded us the opportunity of is discovering new skills, talents, who've actually been coached by some of the longer standing consumers who know the system and know how to navigate it. So we've found a much better relationship there on how do we bring forth new people and really capitalise on those who've been around a while. The guy leaping across the chasm, you know, we have realised that you can't cross a chasm in two small steps, as Disraeli once said. You've got to take leaps of faith setting up recovery colleges, because there are quite a few non-believers, and we have had to dodge a fair few bullets of cynics, critics. We've had some interesting conversations in many recovery colleges around risk. I know ours was not the only recovery college that, when it opened its doors in a typical non-clinical setting, that fairly senior people were saying, we have no panic alarms, we have no security. What if somebody breaks down in a workshop? Some really interesting stuff coming up. I mean, just fascinating. So yeah, we've had to dodge a lot of bullets. The lady looking very stressed out with her list, I think really represents a lot of what is felt in services at the moment. Resources are diminishing. We can't keep doing the same thing with less. We have to do something different, and recovery colleges really do afford us that opportunity, and where we can start with a core like a spider plant and then start planting out and letting things emerge and evolve. That's got to be a good thing for our services in terms of limited resources. The final picture, you might not be able to see him, but there's a guy in the middle of the picture, disguised as a roof and rubble. And I think for me that represents that we have drawn out some amazing skills and talents through this process. People who were just in the woodwork and we didn't realise were there. We found some phenomenal peers, phenomenal carers, whose talents go way beyond them just living with or supporting somebody to live with a mental health condition. Finally, I would just say that I think most recovery colleges have really worked with communities and services to move people to see the words differently. So I think to start with, many people would have read that opportunity is nowhere. And I think recovery colleges have really helped people to read that now as opportunity is now here. And that's a big difference for people. And it's just a different way of viewing things. So I shall leave you with some quotes and ask you to, invite you to ask any questions or comments. So, yes.
I was wondering what sort of proportion of the students at your recovery college were staff members? How that
Right, so in our recovery college, I was only looking at figures yesterday actually, in our recovery college it's around 63% of those who use services. I think the smallest group are supporters and carers, and many recovery colleges are trying to think about better ways of engaging carers without setting up that something's separate. But we know that with caring responsibilities there are often limitations as to when people can get to college. We've tried, as many recovery colleges have, delivering courses on an evening, but it's not about that. We're finding it's not just about time constraints. There's something about carers valuing themselves in terms of thinking about their own recovery. And Veronica, who's on there, who I do a lot of work, she leads most of our co-production workshops now, actually. And, you know, I think we have to have some real ambassadors for our carers to say your recovery really, really matters. And that has been the biggest challenge for us as carers. Staff, I would say, in terms of professional groups, doctors are the ones who come least because, as I say, they don't think they've got anything to learn. But we're seeing a shift there as well, and I think that's partly because we're inviting doctors to co-produce workshops with us, and I think, you know, it's credibility. If you see your psychiatrist is delivering a workshop on medication, then you're more likely to turn up because it gives you brownie points as another doctor. So there are ways. I think we have tackled some of those issues around professional groups by, this is a tip actually I got off Dr. Rachel Perkins, which was we were delivering basic introduction to recovery workshops, and we found when we looked at the staff complement who were coming, there were no team leaders, managers, or very senior people. So we started calling it a masterclass, and everybody came. It was incredible. So yeah, I think there are ways of, we've got to be a bit creative but I think once we draw people in, then they come back. You know, when we look at our kind of stats, we see that once people come, yeah, they'll definitely come back. Yeah.
Janie, I'll remember that when I was writing down a masterclass. Another element in the room, another elephant in the room, sorry, surely is economics.
Yeah.
Funding, sustainability. Now, as you said, and it was clear from some of the photographs or some of the bits of the video, the central and northwest London facility, could be called a bit flash.
Yeah.
So, are there partnerships or arrangements or collaborations where the college is hosted?
Absolutely. So, and this applies to all recovery colleges. So, for example, a great example at the minute is living safely around fire safety and stuff, living in your home in Nottingham. The recovery college workshops delivered in the fire station. That's where it's hosted. We host recovery college courses in libraries, community halls. Our Salvation Army are our favourites because they always provide us with refreshments. We deliver stuff out of GP practices. It really is anywhere that you build a partnership. That's our hub. But the majority of our workshops, we deliver across about, I think it was about 60 locations. I did jot it down actually yesterday. At the moment we're delivering across around 30 sites. That's just our where we filmed it is our central location. We deliver out of universities and other further education colleges. That's been a really interesting experience for a lot of recovery colleges. We thought everybody would want to go to a workshop in a further education college. Actually, it put off a lot of our consumers because you had to, present at security and say you were going to the recovery college workshop for them to let you in, and then suddenly it felt a bit different because anybody who was going in to study geography didn't have to say where they were going. So, there's been things like that to think about in terms of when we have used venues. But no, we will use anywhere that we can get free. I mean, that is the kind of bottom line, really.
And the free word, does that also link with no cost for the courses?
No cost for the courses, yeah. What we have done and what where recovery colleges are anchored often in services, so the decision in our organisation was there was some additional funding that we got from commissioners when they encouraged us as well to do something different with one of our day services. So rather than cutting the day service money, they said we want you to do something a bit more exciting with it, and that's what set up the core of our recovery college. But then as we expanded, it was, well, who's going to pay for it? And because there was no money coming from commissioners, a decision was made at the executive board level to top slice every service in our organisation a little bit, because the reality was everybody could access it. So why wouldn't you pay? And so we looked at that proportionally. If we had less older adult services, then they paid less. But it was literally top sliced from everybody because it was more than like a cooperative. Everybody's getting a bit, so everybody should pay for a bit. And what was great, what that also led to, though, was also a greater commitment from services to send their staff because they wanted their money's worth. And so there was a great experience in one of our older adult services where the manager said to their staff, we expect you all to go at least once to the recovery college. That should be part of your personal development plan, that you go to a recovery college course, but we always expect you to take along a service user with you who you're working with. And so we've started to see those partnerships as well. To which the individual service user said, yeah, it's the bring along a punter model, Jane. That's what it is. But it's another great way of doing things. It's meant that at areas like eating disorders, perinatal services, secure services, they all want to co-produce because they want to get their money's worth. They want their service users to access things. It's quite a clever business model, really. But yeah, because there was many recovery colleges, it isn't additional funding, it's got to be found from existing funding. Yeah. Yeah.
I don't want to hold all the questions,
Sorry.
but you were talking a lot about the real importance of language and also about getting rid of the power differential in the recovery colleges. And I was just wondering to what extent you've been able to engage people for whom education, and so the words teaching, college, all those sorts of words around education might actually bring back memories of teaching school.
It does.
And so how do you engage those?
So what's been really interesting is some recovery colleges went off very quickly saying that they wanted to accredit their workshops. And actually, that was a very off-putting thing for people who wanted to access it, because it felt like that was too far away, given their previous experiences of having to go on a course that might require them to write something, or indeed sit an exam, God forbid. We almost slipped into that, but the only accredited course that we and a number of recovery colleges offer relates to peer support training, and they're accredited courses with local universities. Really, we've encouraged people to come to taster sessions. In the early days, it was death by taster session. We took taster sessions out to services, because there was a lot of convincing. There was a lot of skeptics who had really, really negative experiences of education. And so it really was about selling the vision of what this was. I think our peer trainers have really, really helped, because we're very fortunate. The peer trainers that you saw up there, so Waldo, who talked about his favourite course being Taking Back Control. Waldo was street homeless for 15 years, fell out of education, and so peers are going around talking about their experience of how this is different to all of that. And I think the colleague this morning said that was especially important with the CAM services, the children and young adult mental health services, because they're kind of experiencing difficulty now in education. So why would they want to go to a college? But I think there are ways around that. It's very different. It's the principles are there, but the expectation is very, very different. And the other thing that we discussed at length this morning was people's genuine learning needs that get in the way of them accessing education. So both on enrolment and individual learning plans, we do a lot around ensuring people can access the recovery college. So we have quite a high rate of dyslexia, students reporting that they're dyslexic. We've had a number of things. Language in Westminster, we have over 100 first languages spoken in Westminster, that borough, so we use interpreters. We often have study buddies with some of our service users who have learning disabilities but don't want to go to a learning disability course, they just want to come to a mainstream one. So yeah, there's lots of things that we've had to think about and just build up gradually and respond, really. You kind of almost don't know what you don't know when you first start off, I think, with a recovery college, and that's okay. That is okay. Yeah.
How do you decide when you think you've got a good service, or how do you also decide when a service isn't working?
I think for us, we have tried to stay very committed to recovery, the principles of a recovery college, and not veer into therapy and all of that. We have so much feedback that we have used from day one. So when we first set up, even at the end of our first pilot term, which was only 10 courses, because this was quite new to many of us, we actually got an external consumer group to come in and run focus groups, because we almost wanted to make sure that after the first term we weren't heading off in the wrong direction. So we brought in external folk to facilitate workshops with students, both staff, carer students and consumers. At the end of every workshop there's a feedback form. At the end of term we do random calls to students to get their feedback. We've got a whole host of different ways of evaluating workshops. We adopt a bit of a mystery shopper approach to workshops and courses, just to keep trainers on their toes. So we have a lot of ways of evaluating, but it's student feedback is what we're really reliant on. And I have to say that people are very honest. If they think that something's not good, they will tell you. Yeah, just that gentleman behind first. Yeah, you.
I'm Amit. I'm a psychiatrist and I'm a member of the expert panel. So, has any of the courses gone down the path of discussing diagnosis?
Oh, absolutely. Most of them do.
Okay.
Yeah,
so
and
does that become contentious?
Oh yes, definitely. But that's the joy of a recovery college. We want it to be contentious. You know, we need things to be shaken up a little bit. And of course it's contentious, because what you have in a room is people with lived experience of being given that diagnosis, and often professionals who have been the ones who've cast cast the diagnosis upon them. So we really expect all our workshops to carry a heavy evidence base. That is the expectation of every workshop. There is a heavy evidence base that's drawn upon, and there is the lived experience so that people can make their own judgments. So what happens is that, and I was talking to Joe about this earlier, that often there are very different approaches adopted to the treatments for different diagnoses. What we would expect a workshop to do if it was understanding bipolar, for example, is that, you know, that course would be underpinned by theory, talk about how diagnoses are made, what that means to people, ways of managing, living with that condition. There might be a perspective from a doctor about medication and the treatment of it, but that has to happen in workshops. We can't just have somebody coming along grumbling about a diagnosis. You know, there has to be an evidence base so that people can really tease out what are the key issues. A real theme that comes up, and it's not just in relation to diagnosis, is being forcibly admitted to hospital. That comes up an awful lot about how decisions are made for us for compulsory admission to keep people on a 6-month treatment order. That often comes up and is explored. And you know, and so again, you get this the view of the Mental Health Act. You get, you know, the perspective of the practitioner. It's raised wonderful conversations, you know, of nurses saying, we too find it really hard when we know you're not allowed off the ward and you can't see your children. You know, there's amazing conversations are going on, and that I think there's been an assumption that it's somehow easy for staff working in some of these environments, and the difficulty sits with the individual who's been incarcerated onto an inpatient unit. And we've had some amazing examples. So there was one workshop that I was in, and there was a consumer there talking about how it had felt to be on a section on the ward. One of the nurses who'd cared for her some time ago was there. And they ended up having this conversation of Sue, who's now a trainer, saying, you know, I remember you moved me outside the nursing office because I was really difficult to manage. And I thought you belittled me all the time, and you wouldn't let me do this and you wouldn't let me do this, the other. And the nurse turned round and said, I do remember caring for you because I was one of the nurses who found you when you tried to hang yourself on the ward. Have you ever thought about the trauma I've carried since then? And these are conversations that just don't normally go on. So the issue of diagnosis, of being forcibly admitted to hospital, medication, all those kind of issues come to the fore.
One question, are you aware of the critical psychiatry movement, and have you had any interactions with critical psychiatry? So well, there's some very interesting movements going on, actually. So in the UK, we see a lot written by a group anonymously called Recovery in the Bin. There's that that's going on, which kind of criticises both the medical profession but equally the recovery movement, which there is a perception that's now been monopolised and taken on by professionals, which, you know, fair point at times. But just going back to what you were saying about this medical perspective, so we did lock horns quite a lot in the early days with some medical colleagues. Many others now co-produce workshops with us, so, you know, it's not an issue. But I think we reached a point where it was back to this, what are we arguing about? What are we saying is so different? And I think where we've reached now is that we're saying the Recovery College should be a place where we can integrate the best of clinical recovery, which is about the understanding about why assessment tools might be selected, why interventions are selected, treatments, evidence-based treatments, so people understand those with the principles of personal recovery, which is around hope, opportunity and control. And that has been the way that we've moved forward with this, because we have to integrate the best of both worlds. You know, we have students who come along who are very anti-medication, but then you'll hear from other consumers who say, you know, that worked for me. It might not work for you, but it works for me.
So it doesn't feel like it's a them versus us, that this is a clear divide between people who are anti-medication, anti-psychiatry. The power of learning happens in the room, and people have got all sorts of different experiences. Some people are really vocal about, the damage that has been done by psychiatry to their lives. But then equally they might be sat next to somebody who says, yeah, but I've had a different view. And it's easy to hear from another consumer who might have a different view than a professional sitting in front and saying, well, we know best kind of thing. The most liberating thing that staff say has happened when they've used the Recovery College well, and this applies to Psychiatric College too, is that they accept that they know less than they thought they knew. That has to be the starting point. Just accept that you know less than you thought you knew. And that's what we're trying to instill in professionals coming to the Recovery College. Because it's not just our doctors. There are other professional groups who equally are very wedded to their views, really, and their training. So, yeah.
Sorry, I have to run. Thank you so much.
Oh, thank you.